Hello friends, welcome to the session of Conceptual Spine Connect today where we are going to discuss the last session of the thoraco lumbar fractures. So last time we discussed the conservative line of management, the brace, the medicines, the form of therapy and hot fomentation and everything. And whenever these patients are having unstable fractures and along with that deficit and whenever these injuries come in the category of surgical management, so we are going to discuss that today. So what are the goals of surgery? So whenever these patients are to undergo surgery, the first goal of the surgery is to achieve and maintain the anatomic reduction and stability. So whenever there are dislocations, whenever there are subluxations, whenever the column is moved, so our aim is to get the anatomical reduction or the bones back in place and to stabilize them. Along with that, if there is significant amount of compression, we have to decompress as well. That is decompression of the spinal cord or the nerve roots. We have to do all this ensuring that we minimize the length of the construct. We cannot have keep on having a very big construct or keep on increasing the size of construct. Along with that, we have to aim for immediate mobilization and early rehabilitation. So we have to mobilize the patients as soon as possible and rehabilitate the patients as well. Indications. So what are the indications of surgery? Whenever the patient has got an incomplete deficit, whenever the patients have got a progressive deficit, so whenever the patients have got an incomplete deficit, so we have to try and get the neurology better and back in place. Whenever the patients are having a progressive deficit, that is, they had a deficit, they are having real-time increase in the amount of weakness. Whenever the patients are having ongoing spinal cord compression, the cases with fracture dislocations, whenever the kyphosis or the deformity is such that the angle is more than 30 degrees, whenever there are concomitant injuries which necessitate early immobilization, we cannot put the patient on bed. So these are the indications of surgery. That is, whenever the patient will come to us with an incomplete deficit or some amount of deficit, real time increase in deficit, that is progressive increase in the deficit, spinal cord compression, fracture dislocations, kyphosis or the deformity angle more than 30 degrees, injuries which necessitates early mobilization. Timing of surgery. So timing of injury is something that has been studied a lot. A lot of research has been done on it. Vaccaro et al. Found that there's no significant neurological benefit when the decompression is performed in less than 72 hours compared to patients who are having late surgery that is beyond 5 days. La Rosa et al. Divided the patient in three groups: decompression in less than 24, delayed decompression more than 24, and conservative treatment. And they reported the better outcomes in patients undergoing early decompression as compared to patients with delayed decompression or conservative management. In presence of a progressive deficit and spinal cord compression, it is definitely important to do a early stabilization and decompression. And in fact, in these patients, we might even do the surgery at 2 o'clock in the night because of the ongoing deficit and compression. What are the different surgical approaches? So the different surgical approaches in which this surgery may be done is either a posterior approach or an anterior approach or a combination. So let's talk about the posterior approach. So most common approach, it is the posterior approach for vast majority of the thoracolumbar fractures. Unstable fractures with intact neurology, flexion, distraction injuries, trans fractures. Rotational and shear injuries also easily are reduced and stabilized via the posterior approach rather than an anterior approach. So whenever there are dislocations, whenever there are significant amount of rotation that is involved, facetal dislocations, and so these are the injuries which can be easily reduced and stabilized via just a posterior approach rather than going ahead anteriorly, because anteriorly becomes a bit morbid with respect to exposure and reaching the spine. Posterior pedicle screw fixation has shown to be a simple, familiar, reliable, and safe in regards to the achieving the reduction and also stabilization for most of the fractures, and it remains the most popular technique. So back in the days, anterior surgeries were done. Eventually that got shifted to posterior surgeries because of the ease, reliability, and also the pedicle screw construct is such that pedicle screw gives a 3 column purchase in the spine. So that basically has given a better preference or preferential surgery, that is a posterior surgery rather than the anterior surgery. Ligamentotaxis. So what is ligamentotaxis? So that this is one technique in which we achieve an indirect decompression. So what is direct decompression? Direct decompression is when we do the laminectomy, and once we are basically thumping the fragments back in place or removing those bony fragments which are causing the compression. Against that, ligamentotaxis is a technique indirect decompression. So what is indirect decompression? So this indirect decompression is by doing distraction and ligamentotaxis. So I'm going to discuss this shortly with images. So the best results are there whenever it is done within 48 hours and whenever there is moderate canal compression, only around 50%. If ever the canal compression is such that it is more than 67%, and if the surgery is planned more than 72 hours after the injury, or the fracture has started to consolidate. So these are not the cases wherein indirect decompression is going to work. So early fractures that are reported with only moderate compression are the best ones to treat via this technique. So basically what is done in these type of surgeries is we stabilize the spine, we achieve some amount of distraction as you see over here, and these retropulse bony fragments fall back in place once we achieve some amount of decompression and stabilization. So this is ligamentotaxis. This is possible only when the posterior tension band is intact, so that we just go and do a bit of distraction and push back the bony fragments automatically. So we achieve indirect decompression via ligamentotaxis via this technique. Transpedicular approach, it is a potential indication for a fracture above the conus level with a posterior failure and deficit with canal intrusion. That is, whenever the patient is having a fracture above the level of conus, when the spinal cord is involved, and over there, basically, why above the conus? Because over there, the spinal cord operates a spinal cord occupies a majority place of the spinal canal, and already it is compressed as you see over here by the fracture fragments, and we cannot afford to have any iatrogenic compression further, because these are very critical areas. Because of already the injury, the spinal cord becomes sick, and with any form of further tweaking or mobilization, the deficit can increase. So in such cases where the room of error is very much lesser, this particular technique is used in cases above the corners with a posterior failure, with a deficit, with canal intrusion, as you see over here, with the ventral pieces of bone. So what we do is we basically approach, we remove the pedicle, we approach via the pedicle, and we either remove these fragments or we thumb back them in place. We do this so that we don't retract the dura or conus at all. So as you see, we are approaching via the pedicle. This is the pedicle over here. Remove the pedicle. In fact, as you see over here, some amount, many a times we keep even this medial part of the pedicle intact over here while we start doing the decompression, so that we don't go and touch the spinal cord at all. We go inside, we reach the body from a transpedicular route, thumb back the fragments or remove the fragments or curate the fragments, and so that we give the place to the spinal cord, and then we might consider removing the lamina as well. In the lumbar spine below the conus, as dura could be retracted, and there is we are having the liberty of retracting the dura, moving it a bit. So a direct decompression via the fragments by either the tapping the fragment or direct removal is possible, which is not so in such cases. Costotransversectomy. Costotransversectomy is basically the approach wherein a better direct decompression is done with thorough bony removal. In costotransversectomy approach, we basically go a bit more lateral via the area where there's an articulation of the rib with the spine. We basically knock that articulation off and go start reaching the spinal column from there. We give the anterior support in the form of this cage with the bone graft, and we do the deformity correction via doing the corpectomy or complete removal of the bony structures. Indication: a patient who has got thoracic or thoracolumbar injury, L2 level or above, with a failure of posterior tension band and a significant anterior column injury with or without a retropulsed ventral fragment and deficit. So basically, again, I'm repeating what are the indications in fractures at the thoracic or thoracolumbar junction, that is L2 above, when there is a failure of posterior tension band with a significant anterior column or the vertebral body involvement, with or without the retropulsed fragment with deficit, wherein we have to completely remove the vertebral body. So in such cases, this particular approach is recommended. What are the disadvantages? Instrumentation failure is something that is known with this approach. Pseudoarthrosis or failure of union or fusion is also known. Infection, risks of spinal cord injury, inadequate decompression, insufficient correction of kyphosis, and the need for late instrumentation removal. So these are all the disadvantages with the anterior approach. Anterior approach, the major disadvantages is not a complete correction of kyphosis, I would say, and also